Men, are you struggling with ED? In this episode, I'm having a unique conversation with Dr. Mohit Khera from Baylor College of Medicine, a world-renowned urologist and an expert in erectile dysfunction. He will share his perspective on treatment for erectile dysfunction and discover how you can regain your confidence and your sexual vitality again. And you do not have to live with ED. So stay tuned for this whole episode. I will guarantee you will learn something powerful. Hello there, modern man. In today's episode, we have one of the best urologists in the country, Dr. Mo Khera, because I have been admiring his work for years, and we both graduated from the same program. So Dr. Mo Khera is the professor in the Department of Urology at Baylor College of Medicine and hold the F. Brantley Scott Chair at Urology. We'll dive into what that means. And he has published hundreds research paper on men's sexual health, and is really the leading researcher and clinician in men's sexual health. So I am so honored to have him here today in our episode. So welcome, Dr. Khera.
Thank you so much for having me on the show.
Okay, so I'm going to ask you some questions that I wanted you to share from your perspective. What is the latest in men's health at this time? What's working, what we're finding out that may not work? Because I know you on the cusp of research and about to do great research coming up, and I'm going to be following you. And as listener, follow him because he is the best in what he does in male sexual health.
Thank you. That's a loaded question because there's so much innovation and change going on in men's health and sexual health as we speak right now. But I think the biggest thing for me is this full paradigm shift from being proactive and reactive. Historically, when in sexual dysfunction, we've been very reactive. We wait till the man gets erectile dysfunction, he comes into my office, I give him Viagra, and he goes on his way. That is reactive. And what we're now seeing is we're changing the paradigm. We're being proactive. We're preventing the erectile dysfunction from happening in the first place. And how do we do that? Diet, exercise, sleep, stress reduction. People are becoming much more aware of their bodies and preventing it. They're taking more care into their hormone profiles, looking at their testosterone level. Women, for example, their estrogen, testosterone, progesterone. And we're also focusing on regenerative therapies. I know we talked about that earlier, just about stem cells and PRP and shockwave. And now we're looking into new things such as radio frequency, potentially hyperbaric oxygen. So there's a lot of new things on the horizon. But I think the biggest thing for me, and I think the most interesting, is this paradigm shift of shifting from, let me just give you Viagra, I'm actually going to give you a treatment like diet, exercise, sleep, and stress reduction.
Wow. So that's a loaded question. What does that mean? Can you clarify?
Yeah.
Diet, exercise, sleep, and stress reduction,
Let's
so
talk.
our listener can have an idea what really that means.
Yeah, let's take a step back. If you look at all the podcasts that we're listening to today, you're going to hear two big buzzwords. The first word is lifespan. The second one is health span. You hear health span and lifespan over and over again. And so, Ann, you and I both want our health span to last as long as our lifespan. I don't want to live till 80, but only be healthy till 60. That would not be good for me. Well, interestingly, most people think about their sex span. Your sex span is the portion of your life where you'll be able to engage in satisfying sexual activity. Most of us want our sex span to last as long as our lifespan. And so that's very important. And so how do you do that? Well, many of the techniques that you're hearing online and hearing on these podcasts of how to improve your health span are the same things that improve your sex span. So when I talk about diets that typically are anti-inflammatory, that have high antioxidants, a low glycemic index, typically have more impact on improving sexual function. The one that's quoted the most is the Mediterranean diet. We have the most data on the Mediterranean diet for sexual dysfunction. Now, I don't think the Mediterranean diet's right for everybody. And I think what's unique about the Mediterranean diet is it's very high in antioxidants It's a low inflammatory diet. We talk about sleep. You need at least 7 to 8 hours of sleep a night to help improve your sexual function. If you get less than 6 hours of sleep per night, it actually is detrimental to your sexual function. It can actually impair sexual function. Some people say, well, doctor, I heard the more sleep I get, the better sexual function I'll have. But that's not exactly true. Roughly around 9 hours, it plateaus. So sleeping 12 hours doesn't make your erections better. You really want to be in that sweet spot of 7 to 8 hours. And remember that it's not just the amount of hours you sleep. We also talk about quality of sleep, right? So you want to have good quality, good REM, good deep sleep. And you also want to mitigate sleep disorders. The number one sleep disorder causing sexual dysfunction in the world is sleep apnea. Sleep apnea significantly increases sexual dysfunction. The number two disorder in the world is insomnia. So just be careful. If you have these conditions, addressing those conditions can make a big difference.
Wow. So I want to kind of circle back a little bit when you say, why is there a paradigm shift from reactive to preventative now? What has happened that created that?
I think the biggest is social media and podcasts. People are listening to social media. They're listening. They did not have this vehicle in the past. And that is really important. If you look at the health podcast, look just like this one. Now, people are getting their education through you, not through the newspaper anymore, not through the TV anymore. They're getting their education through you. And what you'll see on many of these podcasts is they're talking about improving health, improving the quality of health, and being proactive about your health. Whether some people talk about red light therapy, they talk about meditation, mindfulness. I mean, everything is about improving your health. And so these, in effect, are actually improving your sex span. It's the same thing. Let's take exercise for a second. We published a paper 2 years ago showing that exercise alone, just exercise, significantly reverses erectile dysfunction. In our study, we looked at 11 meta-analyses, and it was on average 40 minutes 4 times a week. That's all you got to remember. 40 minutes 4 times a week. It's 160 minutes over a period of 6 months, significantly increased the IIEF, or the erectile function scores. What's so interesting is the more severe the erectile dysfunction you had, the greater the improvements in IIEF scores. And that's just with exercise, right? Now, if I tell someone to do 40 minutes of moderate to vigorous exercise 4 times a week, I will significantly reverse and improve their sex span. But guess what, Ann? I'm also going to improve their health. I'm also going to improve their lifespan. I mean, I get other benefits besides just improving their sex span. So I think the same principles that we use for health span and lifespan absolutely apply to sex span.
So I love how you use the word sex span. That's the first I've heard of it. And it's almost like, hey, if you improve your sexual health, you will live longer. So that may motivate people to correlate both of it, because everybody want to live longer and be healthy.
Yes.
And have quality of life. But what we find out in this field is that it's so hard to motivate people to exercise.
Yes, no, I agree. But I will tell you a very interesting story. There was a study that came out of St. Louis, and they were looking at young men, 18 to 40. And they looked at them coming in with a diagnosis of ED, and they would screen them for diabetes. And what they found was that roughly 30% of the men who came in for a diagnosis of erectile dysfunction had actually pre-diabetes or diabetes undiagnosis. That's a lot of people, 30%. Now, I want you to think about when you and I were 30, 25, 30. We don't go see the doctor. A 28-year-old, I'm not going to go in and go get my blood pressure checked. I have other things to do. I'm not going to go in and get my cholesterol, my sugar checked. But if a 28-year-old man gets erectile dysfunction, he is the first person at my door tomorrow morning saying, I got a problem. And why is that important? Because I believe that sexual dysfunction is the gateway to treating all the other medical conditions. If he's going to come in for that moment, I have a window and opportunity to screen that hemoglobin A1C, to look at those lipids, to see what else is going on with his health. And if I tell him that if you improve your blood sugar, you will actually improve your sexual function, many men are more motivated to do that than if I just say, hey, you got prediabetes, keep an eye on it, let's try to improve it. They will be more motivated to take care of their health through sexual function. And that, in a way, has a trickle-down effect on all the other comorbidities.
Right. So that's going to lead me to the next 2 questions. So since we're talking about younger men, what's going on? Why are we seeing younger men now with ED. We should see
Yeah.
that more in the men over 60 or over
Yeah.
50. Why? What's going on?
Let's look at many different reasons why. We'll start with just a general statement about the population is becoming more unhealthy decade after decade. If I showed you a graph of obesity, diabetes, and metabolic syndrome, a graph, and I show you decade by decade the percentage of men who have obesity, diabetes, and metabolic syndrome from the ages of 18 to 40, you're going to see it skyrocketing in the United States like this. And that line's going to mimic ED rates in men as well in this population, because diabetes is the number one risk factor of having ED, 4 times more likely. Obesity, all of these conditions also significantly drop serum testosterone levels, no question. So as I drop the serum testosterone level, as I become more obese, diabetes, these are comorbidities that will take a hit on erectile function. Number 3 is that there is now an era of social media. And what's happening is the porn has significantly increased. And when you see a significant amount of pornography, what happens is your expectation is far greater than your reality. And so that delta can cause many of these men to develop erectile dysfunction. So we ask them, do you have, many men say, look, I have ED, I can't get erection. I say, how about by yourself? Oh, no problem. Okay, then now I got the idea. If you with masturbation, I have no issue. How about in the morning when you wake up? No issue. But with my partner, I have ED. What they're telling you is they have psychogenic ED. And I've seen the rate of psychogenic ED go up. And I think it has to do with porn. I think it has a lot to do with social media and the lack of interaction we all have now. Most of our interactions with the phone and not with other people.
Well, not to mention now AI. I was at a conference and now I'm looking at ChatGPT and you can converse with it now. There's a voice ChatGPT. You can converse with it, even give it a name. It will be as if you're talking to a person. So
Right.
imagine that. If you're at home, you can talk to somebody else you could give it a name. It's like you don't even have to leave the house anymore now, right?
Right. But now there's a whole era of marketing coming out with sexual AI. In other words, you can find a partner online who will talk to you. And there was one study that wasn't a study, it was an article describing a gentleman who had fell in love with his AI bot. And you have to pay every time you talk, and roughly spent almost $2 million in trying to keep this conversation going and this relationship going. So I think you just got to be careful, because I think AI and what's happening in the world of sexual medicine is going to change drastically.
Okay, so what you were saying that was the person was not a person, it was an AI
It was a
bot that he
bot.
was talking to.
Right. Fell in love with, could not stop talking to, was sexually attracted to. And I believe it was roughly $2 million. It was an astonishing number. But in other words, you just have to realize that these AI bots in the area of sexual medicine is growing. There are now virtual reality places that you can go into to have sexual encounters with AI bots as well. So it's changing. Our field of sexuality and how we perceive sexuality, how we have sex is changing.
So what are your views on that when we're now moving to virtual reality and so forth? Obviously, not good because we're social beings and we're taking away that touch and all that sensation. What are your views on that?
So I'm personally against it at this point. I mean, I just feel that there's something important about the human connection. There's something important about being intimate with another person. It's my personal opinion. I think there are others that say this is great. You do things on your own. And personally, I do feel that it's important to have the human connection, keep the intimacy, and keep that relationship going with another person. I think it's important.
You just give me an idea for my next episode to talk about virtual reality, sexual AI. So another question was that you give me a scenario of a younger man who's more motivated because he has ED, and that is a gateway for opening a gateway for better health for him down the road. What about, I wouldn't say older, but a man over 50, 55 that has ED? What would be your approach for him versus a younger male in their 20s?
Sure. Most of the time, the younger patients are more likely to have psychogenic ED. So you just want to be careful about asking about getting morning erections and masturbation. But older men typically have comorbid conditions that they've acquired that have now caused them to have erectile dysfunction. And my only wish, my only hope is that I had the opportunity to meet them earlier in life to where I could change the trajectory. So they're not coming to me at 55 And we could have done things earlier to prevent the ED from happening at that time. Maybe it would have been lifestyle modification, could have been hormonal, could be with your partner. So those are things that you think about. But if he comes in, obviously, I want to first look at everything that could be hurting his erectile function, modifiable risk factors. Maybe it's an SSRI, an anti-androgen. Maybe they're on finasteride. Maybe they're on something that's causing them to have the ED. So you want to take away the enticing, so whatever's causing the ED away. Then you want to look at other modifiable risk factors. And we talked about this earlier, but it's lifestyle modification, diet, exercise, sleep, stress reduction. I want to optimize the hormones, particularly the testosterone level. Optimizing the testosterone can significantly help this patient. And then once you've done all that, you have to make sure you ask about the partner. And I'll just give you a story. When I finished my fellowship, I was very proud of myself, and I was able to get these men, these amazing erections, great libido. And they would go home and they would have no one to have sex with, because their wives would say, one woman called me, she said, look, things were great until he met you. And now we fight all the time because he wants to have sex and I don't. And we haven't had sex in 10 years. And now we fight all the time. And it's because of you. And I thought to myself, she's right. I mean, either leave both libidos low or put both libidos high, but you never put one high and one low, right? That's a big mistake. And so very quickly that year, I flew out. I spent some time with Erwin Goldstein, who's the godfather of female sexual dysfunction, went to a lot of his courses at Ishwish. And for 17 years now, I've been treating women, because by treating the woman, I'm actually treating the man. By treating the man, I'm actually treating the woman. The best examples I can give you, and we've seen this over and over again. Erwin Goldstein did a study with Levitra. He took men and he gave half the men Levitra, half the men placebo. He said, I don't want to meet your female partner, but can you give her this questionnaire at the beginning and the end of the study? It's called the FSFI, Female Sexual Function Index, most commonly used. He gave the questionnaire to all the women at home. What he found was that those men who had Levitra, who had an improvement in their erectile function, those women at home also had a significant improvement in their female sexual function, meaning arousal, libido, orgasmic function. And those men who got placebo, those women saw no improvements in their sexual function. So think about this. And I am actually treating a woman by just treating the male partner. I'm seeing significant improvements, just like I'd see if I gave her a pill or I gave her testosterone. And we did studies showing the opposite. If I treat her and I skyrocket her libido, guess what happens? His erections improve. So it's linked. You can't just treat one person without addressing the other person at home.
Wow. So what you're saying is that if you treat one partner, the other partner will also improve, even though you're not directly treating their spouse or significant other.
Absolutely. Absolutely. Well documented, well shown. So when I treat that male partner in my office or that female partner in my office, I know that the sexual function of the other partner at home will improve. The problem is that we have to actually address what's going on. Like, the biggest mistake you can do is give the man Viagra and tell him to go home, not even ask about the female partner. What if this partner does not want to have sex? What if this partner, there's an issue, there's something? You want to address them both as a couple. If you want to improve the efficacy of that whole relationship, giving him Viagra and telling him to go is not the solution. You need to say, tell me about your partner. Is she postmenopausal? Does she have pain with intercourse? Anyone who has pain is going to avoid the activity. How's her libido? Any issue with arousal? Has there been any issues with orgasmic dysfunction? How's the quality of the relationship? Oh, have you seen my sex therapist? She's amazing. So there's things you can do to make that much better. But handing the Viagra and saying goodbye is a mistake.
I love that. And I encounter this a lot where we'll treat the men and they're functioning, but the women who are maybe in their 50s or 60s are going to menopause and said, we're done. We have kids out of the house. We're done. I'm not interested in sex anymore. How do you address that scenario?
So it depends on what the problem is. Let's define what female sexual dysfunction is. FSD has 4 components: decreased libido, decreased arousal, orgasmic dysfunction, or pain with intercourse. If you have one of these 4 and you're bothered by the condition, you suffer from FSD. So if a woman comes in and says, I have low libido, but I really don't care, I'm not bothered by it, I say, okay, then you don't suffer from FSD. How many women in the United States suffer from FSD? 43 to 48%. That is a lot of women. 43 to 48%. How many of those women actually get therapy? Less than 9%. So that is a big population of women that are suffering in silence. I call that suffering in silence. Many of them say, I don't know where to go. Many of them, when they go to their OBGYN, say they don't want to treat it. They don't treat FSD. And so they just try to find ways to get cures for this problem. And it's actually very sad. There should be better resources. The other problem is there's very minimal research in FSD. We have a lot more research in ED, erectile dysfunction, but the amount of money that we spend on FSD is a fraction of what we spend in men. But in either case, if she has those symptoms, then we try to figure out what is the best way to address it. I think that looking at the triangle is very important. For me, the triangle is estrogen, progesterone, and testosterone. Most people only look at estrogen, progesterone. You have to look at testosterone in women. It's extremely important. It's the number one driver for sexual desire in women, even more than estrogen. In fact, a woman makes more testosterone in her body than she does estrogen. So we have to look at the triangle. We look at the outside triangle, which is cortisol. We look at the thyroid, which is very important. A growth hormone, any other outside hormones that we can look at are very important. And then don't forget, I think I tell the woman, this is a 50-50. You're going to help me with diet, exercise, sleep, and stress. Most women I can see start doing some exercise. They do some change their diet. It's the sleep and stress in women that I see take a big hit. And if a woman is fatigued, let's say she's exhausted, it's 10 o'clock at night, and she has a choice between sex and sleeping, she's most likely going to choose sleep. I'm just going to tell you right now. A man, he still may choose sex, even if he's tired. But a woman's typically going to say, and especially on stress, think about this. Many men use sex to relieve their stress. That's a common thing. Many men use sex. Listen, women typically have to relieve their stress in order to have sex. It's kind of the opposite. And I tell these men, I say, look, you want to engage in sexual activity with your wife? Take her to Hawaii, take her on a trip, relieve her stress, help her with anything she can to drop her stress level. Her desire will go up, but take her out of the stressful environment. So again, we're different. And I think it's really important to understand her situation, what's going on, but to not address the female partner when you're taking care of the male patient, I think is a mistake.
And now, do you always do that when you treat the male? You also encourage the female partner to come in as well?
I
too?
do. Many times they don't, but I will go through the same questionnaire and I'll ask the male patient, tell me about her desire for sex. Tell me about arousal. Does she have any pain with intercourse? How old is she? Is she postmenopausal? Is she on any hormones? Is she on any SSRIs? Because that's going to shut down her libido. And say, I'm always willing to help. But many women don't feel comfortable. Sometimes they say, look, I have low libido, but I'm happy with it. I say, great. So that's fine. So some couples do come in together, which is great. And that's a great discussion. Some women come in after I see the male, then they'll come in afterward and say, look, my husband told me that you may be able to help. And I say, great, let's talk. But when they come in, it's not just about handing her hormones and pills. Like, it's not just about giving her estrogen, progesterone, handing her some testosterone, some vaginal estrogen, and saying goodbye. We go heavy lifestyle modification. I mean, she's got to help me with the lifestyle modification, whether it be weight reduction. Now, I have found one thing that's actually helped a lot of men and women more than even hormones. And when it comes to sexual dysfunction, and that's weight loss. You know, when a woman loses 30, 40 pounds, she feels amazing. She feels like a new person, new clothes, new outlook, self-image skyrockets. And obviously helps with the joint pain and the blood sugars and the hypertension and the cholesterol. I mean, a lot of other things improve as well. But we use a lot of GLP-1s in a select population of patients, and putting him or her on the GLP-1 has really made a difference in my practice.
So you put them on GLP-1 and on a hormone replacement therapy at the same time, or you stagger
Yes,
that?
it's synergistic. So remember this, and we're almost done with this. We're doing a trial now at Baylor, where if you give someone a GLP-1 agonist, they actually can start seeing a loss in muscle mass too, unfortunately, because you're decreasing your caloric intake and the muscle mass will go down. In hypogonadal patients or women with low T, if you put them on testosterone and ask them to lift weights, to lift muscle mass, then we don't see a significant decline in muscle mass because testosterone is anabolic. It actually increases muscle mass and decreases body fat. So very important that if you can use these together, they're very synergistic. I'm not saying, treating a man who has a normal testosterone level would not help, putting him on more testosterone, but in most cases, I would say in most cases. But typically I say that these medications, the GLP-1s and testosterone, are very effective together.
So you feel that most men and women after the age of maybe 50, 55, when the testosterone level drop for women and men, that they should be on hormone replacement therapy?
if they're symptomatic. Well, party lines if they're symptomatic, but I would say that I do think that there is beneficial effects beyond just being symptomatic. For example, testosterone is one of the best markers of overall health. If a man has low testosterone, we know that he's at a higher risk of having a heart attack. Non-negotiable. Increases risk for MI. Low testosterone increases the risk of men for diabetes and obesity. Non-negotiable. Increases his risk for bone fracture. We know that osteopenia and osteoporosis significantly go up in these patients. We also know that low testosterone increases the risk for depression. It was my study. Significantly increases depression. So forget sex. If I told you, if I had a blood test that I could order that would give you a window to your heart, to depression, to diabetes, obesity, bone fracture, we know that low testosterone has been associated with prostate cancer risk as well. You show me in another blood test I can get that's a better marker of a men's overall health. It's not TSH. It's not lipids. It's not C-reactive protein. It's not uric acid. Not a single blood test is a better marker of everything I just told you in men's health. And that blood test also gives you a window of symptoms: energy, libido, erectile function. So every man over the age of 40, I believe, should have a serum testosterone level checked annually. And we started a nonprofit. It's called the Testosterone Project. The Testosterone Project has 3 missions. 1, increase testing for all men. Over the age of 40, every man. Number 2, that we should actually deregulate testosterone. It's shocking to me that testosterone, a natural hormone that we make, is treated just like Vicodin, where it's regulated in the same capacity. And 3, the mission of the Testosterone Project is to bring testosterone to women through the FDA and make it available. I mean, think about this. Testosterone's been around since 1935. So that's when it was first synthesized by Budin and Rusica, 1935. Shortly after, testosterone was used in women in the late 1930s. If you and I walked into Walgreens today and said, give me all the testosterone for men, put out over 20 products sitting on top of the counter. If I said, give me all the testosterone products available for women, 0. Not one FDA-approved testosterone product in for women. If we went to Australia, there would be. If we went to UK, we could get a testosterone for women. Not in the US. We have to improvise. We have to use the testosterone for men, use 1/10 the dose. We have to compound it with the cream. We have to be creative. But she can't go in. She says, look, my husband goes in, he pays $10 copay. I go in, I got to pay full price. Why? Why do I have to pay and he doesn't? We both make testosterone. In fact, the woman makes more testosterone than any woman in the body, but I have to pay full price. Why? It doesn't make any sense. And so that's one of the goals of the Testosterone Project.
I love that. I have to check that out as well too. But we know there's always been a sexual disparity in research for men versus women health. Like how many medication there are for ED versus how many medication there are for female sexual dysfunction. And
I want to give you an example of that. So, and remember this, for many years, if in 2014, if you went again to Walgreens and said, give me all the sexual dysfunction drugs for men, over 30 drugs. In 2014, we had 0 approved for women. It wasn't until 2015 when flibanserin got first FDA approved. The first drug for women ever for FSD didn't come out until 2015. Several years later, we had Vyleesi, which came out, and now we have 2. But can you imagine the amount of research that we have devoted to female sexual dysfunction? It's just a fraction. And the amount of treatment options we have for women is just a fraction of what we have for men, which is unfortunate because, as I mentioned earlier, up to 48% of women in the US suffer from this condition. And now I turn around and say, I don't have much to offer you. I mean, fortunately, we have starting to see some traction, but we need more research.
so when you say 48%, is that all from over 40 or just across anything over 80?
I believe it was over 40. It was a Laumann study. Laumann looked at this study, showed 43%, but I forgot the cutoff age where he started, to be honest with you.
Yeah, I think it's over 40. I think we've heard that around 50%.
Yeah.
It's probably an underestimate, actually, because that study was a long time ago.
in the late 1990s. But I do think that it's underestimated. I think many women who suffer from FSD don't talk about it. I mean, there's a stigma about sexual dysfunction. I give you an example. I was giving a lecture and I said to everyone in the crowd, can you raise your hand if you suffer from hypertension? And actually quite a few hands went up. Then I asked, can you raise your hand if you have sexual dysfunction? One hand went up. It was a woman. One hand, okay? And you know very well statistically that that's not true because up to 48% of women will have FSD. And we know if you look at the men statistics, 40% of men have ED at 40, 50% at 50, 60 at 60, 70 at 70, 100 at 100. It is one of the most prevalent conditions out there, but we will not raise our hand for sexual dysfunction. We have no problem raising our hand for hypertension. We have to destigmatize. It's okay to have sexual dysfunction. It's a normal part of aging. It's okay. Now, there's ways to mitigate that and change it, but it shouldn't be destigmatized. You should not be embarrassed.
I love that. So it's okay to have sexual dysfunction. It doesn't mean you're less of a woman or less of a man. And as we work in sexual health, they always think, oh my God, it's like cancer. But it's part of aging, but definitely can be managed like diabetes or obesity. It can be
Yeah.
managed almost the same way. It has a heart condition.
Right. So think about this. If a 60-year-old man comes into me and says, I cannot believe I have erectile dysfunction, what's going on? I say, did you know you're the minority? Did you know that 60% of men at 60 actually have erectile dysfunction? More men at your age have it than do not. And then they sit there and say, oh, and they actually feel better. They realize I'm not alone. Many people suffer from this condition and it's not unique to me. And I think that's very important. We didn't talk about something very important. Sexual dysfunction is one of the best barometers of a man's overall health. That if a man gets erectile dysfunction today, you know that 15% will have a heart attack or a stroke within 7 years. 15%. Many people have also shown that if a man has ED today, he's much more likely to get diabetes, almost 2 times likely to get diabetes than a man who does not. ED is increased risk for not only heart attack and stroke, but increased mortality. Men with ED are much more likely to die, 25% increased risk if they have ED today. So it is a window of not only cardiovascular risk, mortality, diabetes, also depression and anxiety. So it's not just this erectile dysfunction. He's trying to tell you that something's going to come in the future and we need to talk about it and take care of it now.
I love that. And not a lot of doctors are aware of the different treatment for ED other than, hey, they go and talk to their primary care doctor, they give them Viagra, and some don't even do blood work or look at their hormones or
Right.
even assess whether it's psychological or not. They're either on the ED meds and then progressive trimix as well without really looking at the other lifestyle factors that are important that we talk about. And as you know, it just takes extra training. My daughter right now is in medical school. She's in 3rd year medical school here in Virginia. And I'm just flabbergasted at the amount of education they're even getting now. We're talking about 2024, 2025.
Yeah.
She's in her 3rd year, about to become a doctor in about a year. Nothing been taught, even in the 1st and 2nd year, about hormones and hormone replacement therapy or even preventative therapy. They're being taught almost the same thing that I had when I was in med school from 89 to 93. And it's astonishing that there is nothing on hormone replacement therapy. She's rotating through her OB and she's about to do urology to do OB, nothing on hormone replacement therapy for women or even sexual dysfunction discussion, even in her clinical rotation. And we have to learn all of that post-residency or even post-fellowship. Have there been changes in curriculum since you're in Baylor about that at all?
Yeah, so you're absolutely correct. Very few medical schools teach sexual dysfunction. Very few people get their training even in residency with sexual dysfunction and hormones. Most of the time, where they learn it? They learn it from podcasts, they learn it from meetings, CME meetings that we put on. You've been to one, we talked about this in Orlando. I mean, there are meetings that you'll get, that's where they get their education from. It's not during their true medical education training. Now, I'm going to talk about an organization called the Sexual Medicine Society of North America. By far the best organization on the planet, I would say, when it comes to sexual medicine and education. And the Sexual Medicine Society of North America has now started a new initiative to significantly increase medical school education in sexual medicine in all 50 states. And so basically help support it, have champions located in medical centers in all 50 states. And those champions will have monthly meetings. We currently are doing this already. And we meet with the medical students and we teach them sexual medicine once a month. We've been doing it at Baylor now for 3 years, once a month, every month. We meet with all the medical students who are interested. They come, we have some dinner, and we talk about sexual medicine. These are called RIGs, regional interest groups. And so we're trying to significantly increase medical school education because I think it starts in medical school. It's even because that's when you can get the interest better than even getting a residency. Teach it in medical school, make it a true curriculum. And we're actually helping, the SMSNA is helping develop the curriculum for those medical schools.
Oh, that's wonderful. I am really glad to hear that. And you're still the chairman of the
I just
society.
finished my presidency. So it's a
Okay.
2-year term, and I just finished my presidency of the SMSNA.
Gotcha. And I'm proud to say that I'm also a member as well of this association. I love the blog that you guys publish, and I love that initiative. And I wanted to share that. So I want to touch upon what is your approach on the psychogenic ED component, because that is really intertwined with
Yeah.
the physical ED. Yeah, you have physical ED, you're going to have psychological ED, and they're kind of almost interchangeable. And I find
They
that
do.
sometimes that is more challenging to address the psychological component because it not involve the man, but also their partner as well.
Right.
So what is your approach on that?
So I think let's take a step back and look at exactly what's happening in this situation. Let's say a man has erectile dysfunction just once. Maybe he drank too much that night, or he just had erectile dysfunction. When he engages in sexual activity the next time, many men are saying, I hope I don't get erectile dysfunction again while they're having sex. As they say that, and they're fixated on not getting erectile dysfunction, they're going to get erectile dysfunction. In other words, they're more consumed. Then they'd have sex again, and now say, look, I've had it twice. Sex now becomes anxiety provoking. They start getting nervous when they say, I hope it doesn't happen. So I call it the vicious cycle. The more sex they have and the more ED they have, the more ED they're going to have. It just kind of gets into their head. So what you have to do is ask them certain questions. First of all, they say, with masturbation, do you have any problems? No. Okay, that's psychogenic. If you get up in the morning, you wake up and you have more strong morning erections, yes, then that's psychogenic. It means the hardware is working fine. Everything is working fine. It just doesn't work well when you're with your partner. That is psychogenic ED. So a person who has true ED would not be able to get great erections with masturbation or wake up with morning erections because the erections don't work. So that's very important. What's my favorite way to break psychogenic ED? My favorite way to break psychogenic ED is daily Cialis. When I give a man daily Cialis, many of these men will start waking up with morning erections. And when they engage in sexual activity, many of them don't need to take a pill. They just have sex when they want to have sex. They feel normal again. And when they feel normal again, and every time they notice, hey, past 10 times I had sex, everything was great. I had no ED. Then I start taking back the Cialis little by little. You can take it to every other day. Then you can take it to twice a week and you can stop. Many men don't want to stop the Cialis. And I think Cialis is a fantastic medication. It's FDA approved for ED, FDA approved for BPH, FDA approved for pulmonary hypertension. It protects the lining of the blood vessels, it protects the endothelium. It's a win-win-win on all three. So I really recommend those, particularly for the men over the age of 50. So I think that psychogenic ED can be broken with that kind of showing them that everything's fine. You make a referral to a sex therapist. Most of them will not see the sex therapist, but it does help seeing a sex therapist. And getting a penile ultrasound and showing them that everything is perfect actually is very therapeutic to them as well. Oh, look, Mr. Smith, your peak systolic was 40, was fantastic. Your end diastolic was only 2. You have very healthy blood vessels in the penis. They feel better. They actually feel better knowing that everything is fine.
I love that. And I actually do that a lot. I've learned penile ultrasound from the urologist here, and it's the best thing you can do because it's objective evidence that, hey, everything is working. The plumbing is working really, really well. And so
Don't forget to ask about the quality of the relationship, though. That's really important. The quality of the relationship, I don't care how much medication I give you, if the quality of the relationship is poor, it will have a big impact. And not knowing that piece of information will make it more difficult to treat that patient.
Well, let's say the quality is poor. As the doctor, what can you do about it?
We have 3 phenomenal sex therapists that we use. And actually, they're different ages and they have different personalities. So I kind of tailor my referral to that right person that I think will suit the best for that with that sex therapist. They're all amazing. But I do think that seeking sex therapy would be important. I think also making sure that the partner does not suffer from FSD. Some of the reasons that could impair the quality of the relationship is if the male partner is constantly wanting to engage in sexual activity and putting pressure when she does not want to engage in sexual activity, that can make it very challenging. So you have to take a deeper dive on her and find out what's going on, and vice versa when I'm treating the female patient. That it's very important. And libido is interesting. Don't forget about what I teach the residents called PET. PET stands for prolactin, estradiol, thyroid, and testosterone. Check the PET on anyone who has low libido because those could be off.
So PETT?
PETT.
Yeah, so check the testosterone, thyroid, estrogen. That's right.
All very important when you talk about libido and sexual orgasmic function as well.
Right. That's exactly what I checked too. So oftentimes we see men, they come in and the only thing that's checked is total testosterone. That's
Yeah.
it. No SHBG would stand for sex hormone binding globulin or estradiol or anything like that. It's the whole picture. Testosterone. If you're listening to this, man, if total testosterone alone is going to tell you the whole picture, what's going on in the body. I hope you enjoyed the episode. I know it's long, but it's packed with great information. Let me know how you think about it. I love to hear from you. I would appreciate it if you subscribe, hit the notification button, and share it with somebody you know that can benefit from this, because you may help somebody without even knowing about it. And also, do not suffer with ED. Do not suffer in silence. There are solutions out there. So check out the Modern Man Club. It's a space where I share information on how to get out of ED and for you to regain sexual confidence again. And together you can get out of ED and have solution for sexual confidence. So check it out at noedman.com. I hope to see you in there, and I will see you in the next episode.